The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk.
You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers.
Hello, Sky Women. Welcome back. I want to start this episode with an admission. I'm a board-certified OBGYN. I'm a Menopause Society certified physician. I'm a fellow of the International Society for the Study of Women's Sexual Health. I perform hysterectomies, and I have spent years not having good enough conversations with my patients about what might happen to their sex life after surgery. Not because I didn't care. I do care deeply, but because training doesn't prepare us well for this. And there's this cultural habit in medicine of treating sexual function as this secondary, right? I mean, what did I learn about the clitoris in residency, except for that she existed right there and all we saw with the glans clitoris and diagrams, boom, that was it. So this is seen oftentimes as just something to sort out later, right? We're taking care of bigger things there. It's kind of like after a cancer diagnosis. Well, you've been treated for cancer. Now you have these other side effects that are affecting your quality of life. And oftentimes, you feel dismissed as if the doctor is like, you should be grateful to be alive and you shouldn't be asking for more, right? We have to have these conversations because it is serious and my patients deserve better. So today I want to give you the conversation I should have been having all along. Today we're talking about orgasms after hysterectomy. So let's set the stage. Before we can talk about what changes and why, I need to make sure that we're on the same page about what a hysterectomy actually is, because this is not one surgery. It's a family of surgeries, and the difference matters enormously for sexual function. In the United States, about 600,000 hysterectomies are performed every year, and that's more than one every single minute. We perform them at about triple the rate of most developed countries. The indications, the reasons why we do it include cancer, life-threatening bleeding, severe infection, fibroids, endometriosis, adenomyosis, pelvic pain, uterine prolapse. Importantly, cancer and true emergencies really only account for about 10% of those cases. The remaining 90% are benign or non-cancerous conditions. Why does that matter? Because the vast majority of patients, there is time to have a full conversation, time to explore alternatives, time to ask good questions and get good answers. And so often, I know this from my own practice, that time just isn't well used. And in a traditional insurance-based model, it's very challenging when you're having to crank through 20, 25, sometimes 35, 40 patients a day. It makes it really challenging to get all those questions answered. So let's have a comprehensive conversation. So the type of hysterectomy. First, what gets removed? A total hysterectomy removes the uterus and the cervix. This is the most common type. And often, actually, now we're doing our total hysterectomy includes not only the uterus and the cervix, but also the fallopian tubes. This is the most common type. A supracervical hysterectomy, sometimes called a subtotal or partial, removes the uterus but leaves the cervix in place. A radical hysterectomy performed for cancer removes the uterus, the cervix, the upper vagina, the surrounding lymph nodes, and supporting structures. Then there's the separate question of ovaries. Removing one ovary or both ovaries, called an oophorectomy, can be performed alongside any type of hysterectomy, but it's a distinct decision. When both ovaries are removed, a woman enters surgical menopause immediately that night. I'll come back to that because it has important implications for sexual function that require their own conversation. And finally, the surgical route, how we actually get there. Abdominal hysterectomy involves an incision in the belly. A vaginal hysterectomy is performed through the vagina with no abdominal incision. And laparoscopic or robotic hysterectomy is a minimally invasive approach through small incisions using a camera and instruments. And there's also a laparoscopic assisted vaginal hysterectomy. And there's also laparoscopic hysterectomy done through the vagina. Like there are multiple approaches to a hysterectomy. Each approach has different implications for recovery, nerve preservation, and potentially for sexual outcomes. So the combination of what's removed, how it's removed, and whether the ovaries come out creates very different surgeries and very different impacts on sexual function. And this is why I had a hysterectomy doesn't tell the whole story. And this is something I ask my nurse every day or my MA whenever they're rooming patients and they come out and say she's had a hysterectomy. I say, what kind of hysterectomy? What's actually happened here? All right, now let's talk about the anatomy of an orgasm. So here is where we get the part of the episode that I think is genuinely underappreciated, even among physicians, because to understand what might change after a hysterectomy, you have to understand how orgasms work in the female body. And it's more complex than most people, including most doctors, realize. We know that like sexual desire is a biopsychosocial approach in terms of like if we're having a reduced desire and that there's so many aspects that play into that desire. We're not talking about desire here. We're talking about the specifics of the physiology of an orgasm. There are multiple paths to orgasm in women, and they're served by different nerves, and this is critical. So the clitoris is primarily innervated by the pudendal nerve, and this nerve enters the spinal cord at the sacral level, and it is generally not affected by a hysterectomy. So for women whose primary and predominant pathway to an orgasm is clitoral stimulation, the surgery is unlikely to have significant change with that experience. The vagina, in particularly that anterior wall of the vagina, the area associated with the G-spot, is supplied by pelvic nerves. And these nerves run in close proximity to the cervix and the uterus, and they could be affected depending on the surgical approach. The cervix and uterus are supplied by hypogastric nerves. And also, this is the part that still fascinates me as someone who studies this, the vagus nerve. The vagus nerve is how some women with a complete spinal cord injury can still experience orgasm with cervical stimulation. Now, here's what that means practically. Okay, 94% of women orgasm through clitoral stimulation. And if you have not looked at the clitoral anatomy lately, I have lots of pictures even on my Instagram page of the clitoris. I wish I had one with me today for recording. She is mighty. We see in diagrams the glans clitoris, but she actually takes a deep dive and has this two bodies and crura. And this is all erectile tissue. It's equivalent to the male penis. And so that's why so many women receive pleasure and arousal and orgasm through stimulation to that clitoris. That's usually external stimulation, touching the vulva. Now, some women report experiencing orgasm through cervical stimulation during intercourse and even vaginal stimulation. And the percentage, when you look at the percentages, they don't add up to 100% because they're not mutually exclusive. Many women experience multiple of these. And then there's a fourth element that I hear about constantly from patients, the sensation of uterine contractions during an orgasm, that type of rhythmic pulsing. For some women, that is orgasm, or at least a central part of it. And without a uterus, those contractions can't happen. That is just simple physiologic reality, right? So here's the question that research shows almost nobody asks before surgery, including me, until the last year, more often than I'd like to admit. How do you experience orgasm? Where do you feel it? What contributes to it? Because that answer completely changes the calculus of what this surgery might mean for you. A landmark review paper from researchers at Rutgers went through decades of published studies on hysterectomy and sexual function and found that virtually every single one failed to document women's preferred source of genital stimulation before surgery. They called it a glaring omission, and they argued, and I think correctly, that this missing piece is exactly why the research results are all over the place. When you don't sort women by how they experience pleasure, you're averaging together people for whom the surgery is completely irrelevant to their orgasm with people who are losing their primary pathway, and the picture gets really muddy. So what does research show? Let me be honest with you about the state of the evidence, because I think patients often get a simplified version of this. The overall picture from the literature is that sexual function after a hysterectomy is mixed and highly individual. Many women report improvement, and that is real when a woman has been suffering from painful, heavy, unpredictable periods, or from dyspareunia, from adenomyosis, and where the endometrial lining is invading into the body of the uterine muscle, that myometrium, and it creates pain with any pressure or stimulation to the cervix and movement of the uterus. That painful intercourse caused by endometriosis or fibroids, removing the source of that suffering can be genuinely liberating. And for some women, they feel so free also because they don't have to worry about pregnancy as well. So they can be present during sex in the way that they couldn't before. And that truly matters. But almost every study, even the ones with positive overall outcomes, also report that some women experience a decline. The research consistently finds that meaningful minority of women report reductions in orgasms, frequency, intensity, libido, and vaginal sensation after surgery. So one of the most important findings in research involves the comparison between a total hysterectomy where the cervix is removed and a supracervical hysterectomy where the cervix is preserved. And it's rare. I can tell you, I can count the number of supracervical hysterectomies that I've done in my career, just simply because it usually makes sense to remove that cervix. But the landmark study found that after a total hysterectomy, the proportion of women experiencing fewer orgasms increased significantly from before surgery to the 12 months post-surgery. After a supracervical hysterectomy, that same measure barely changed. So that might be meaningful data, and it makes physiologic sense. The cervix is not inert tissue. It has its own rich nerve supply. It contributes to the nerve plexus that governs arousal and orgasm, and removing it, depending on the woman, could matter. I want to be careful here not to oversimplify, though, because there are legitimate medical reasons to perform a total rather than a supracervical hysterectomy. If there's a cervical pathology, if cancer risk is elevated, if there are other factors, the cervix may need to come out. And for women whose organs are primarily or exclusively clitoral, the difference is not going to be noticeable. But the research does not support the reflexive dismissal of the cervix as irrelevant to sexual function. The data and the patient's testimonials say otherwise. Let's talk about when the ovaries have removed. I want to spend some real time on this because it's so important and so often handled inadequately. Like even at the last Ish-Wish conference, a physician stood up and had a hysterectomy and had her ovaries removed. And they were waiting until 6 months to start her on hormone therapy. And she was miserable with hot flashes and night sweats and disturbed sleep. This is malpractice in my book. I mean, this is just totally unnecessary. When both ovaries are removed, what we call a bilateral salpingo oophorectomy, a woman enters surgical menopause immediately, not gradually, the way natural menopause unfolds over months or years, but that night. Her estrogen and testosterone levels drop precipitously. Both of those hormones are essential to sexual function. Estrogen maintains health, elasticity, and lubrication of the vaginal tissue. Without it, the vaginal walls become thin, dry, fragile, a condition we call genitourinary syndrome of menopause. Sex becomes uncomfortable, painful. Tissues that were once resilient become vulnerable. They're friable. Some people even get fissures just from the traction or the friction of sex, or even sometimes with wiping. And it's so important that we treat this with vaginal estrogen or a vaginal DHEA. We actually had a recent study come out comparing vaginal estrogen and DHEA, and they both work really well. If we're having painful intercourse in postmenopausal state, vaginal DHEA often works better because it's that precursor to estrogen and testosterone, and there's a lot of testosterone receptors, especially in the vestibule. And for the overall vaginal health and integrity of the vaginal tissue, that vaginal estrogen works best. And so it really kind of depends on what you need. Another trick, if we're having pain at entry, is to use a compounded estrogen testosterone cream to the vestibule. And that, in combination with estrogen intravaginally, oftentimes is a winning combination. I actually had a patient come in 2 weeks ago who's having pain-free sex for the first time in 6 years in that menopausal state with the combination of vaginal estrogen and estrogen testosterone cream with the introitus. So can be life-changing. Now, testosterone, which women produce, and some people are surprised by that, but yes, it is a human hormone, not a male hormone. When we remove the ovaries, we can eliminate up to half of the women's testosterone production, and that can be significant for a lot of reasons. Now, specifically, the research consistently shows arousal, desire, orgasm, function. Testosterone is important, and so we want to make sure that we consider that. I want to say very plainly here, as a physician who performs these surgeries, if a patient's ovaries are being removed, hormone replacement therapy should be offered immediately, not at the 6-week post-op visit, not 6 months, immediately on discharge in the surgical plan. This is not controversial from an evidence standpoint. The Menopause Society, the organization that certifies my expertise in this area, is clear on this. For premenopausal women undergoing surgical menopause, the risk of not treating with hormone therapy generally outweighs the risk of treating, except in specific conditions like a hormone-sensitive cancer. The options are real and effective. Systemic estrogen addresses hot flashes, night sweats, mood change, sleep disturbance, sexual symptoms. Local vaginal estrogen that I just talked about, which stays in the vaginal tissue, doesn't circulate systemically, is particularly effective in maintaining vaginal health and can be used in women who can't or don't want to use systemic therapy. Testosterone therapy, when appropriate, can make a significant difference for libido and arousal and energy and even brain fog. Vaginal DHEA can help. It converts into estrogen and testosterone and for that local vaginal tissue. And it is also FDA approved for that purpose. And I will tell you what I tell my own patients, it's not a one size fits all. We tailor hormone therapy to each person's history, symptoms, preference, goals. But the conversation should happen every time. So if you're facing a hysterectomy with an oophorectomy and your surgeon has not discussed hormone therapy with you, please ask. And if you're not able to have that conversation comprehensively, ask for a referral to a menopause specialist or a sexual medicine specialist. Also of note, when we are removing the ovaries and undergoing surgical menopause and you have a history of endometriosis and you're going to start estrogen replacement therapy, we typically are replacing that systemic progesterone as well to reduce any endometrial implants from being stimulated. Okay, so let me give you some realistic, honest expectations, not false reassurance, not unnecessary alarm. If your hysterectomy is being performed for a benign condition that has been causing significant symptoms, heavy bleeding, pain, pressure, this is a real and meaningful chance for overall sexual experience to improve after surgery. Symptom relief is powerful, and being able to have sex without pain, without bleeding, without anxiety about your cycle, that can open things up in ways that you are genuinely positive. If your cervix is preserved, if you have a supracervical hysterectomy, your risk of experiencing significant changes in your orgasm may be lower, particularly if you rely on deep internal stimulation. If your cervix is being removed and you're having a total hysterectomy and you rely significantly on cervical pressure or deep vaginal stimulation for orgasm, there is a possibility that could change. I'm not saying it's certain. I'm not saying it's I'm just saying it's worth knowing and discussing. If your ovaries are being removed and you begin hormone therapy promptly, many of the hormonal effects of sexual function can be mitigated. Without hormone therapy, the decline in desire and lubrication and sensation, not to mention just your overall well-being and how you feel and function in your day-to-day life, can be significant and rapid. Specific things that may change. The sensation of uterine contractions during orgasm will not be present if the uterus is removed. That is an absolute. The vaginal sensation, particularly in the upper vagina where the cervix may be reduced in some women. The vagina may be slightly shortened after surgery, which is usually not noticeable during sex, but can occasionally affect comfort with deep penetration. Clitoral sensation and clitoral orgasms will not be affected directly by your standard hysterectomy. The nerve supply is distinct and is not typically disturbed. And remember, the majority of women experience orgasm through clitoral stimulation. And psychological factors are real too in both directions. Some women feel grief after their hysterectomy, particularly after, around fertility or the sense of femininity, and that can affect sexuality. Others feel profound relief, and that psychological shift can be sexually freeing. Both are valid. Neither cancels out the physical reality. So, counseling. This is the part of the episode where I put on my self-critical physician hat, because I want to tell you what good pre-surgical counseling on sexual function should look like, so that you can advocate for yourself if you're not getting it. So first and foremost, your surgeon should ask you about your sexual function, not just about your sexual activity, but a real conversation. Do you experience pain during sex currently? Do you have concerns about how surgery might affect your sexual response? Are there specific aspects of your sexual experience that feel important to understand in the context of surgical planning? Second, and I cannot emphasize this enough, someone should ask you how you experience orgasm. Is it more primarily clitoral? Does deep vaginal stimulation play a role? Do you experience cervical sensation during sex? Do you feel your uterus contract during an orgasm? This is clinically essential information, and it is almost never asked. So, third, the surgical plan should be explained in light of your anatomy, your sexual experience. If you rely on cervical sensation and your surgeon is planning on a total hysterectomy, that's a conversation. Maybe a total hysterectomy is medically necessary. Maybe it isn't, but you should know either way. Fourth, if an oophorectomy is planned, if we're planning on removing those ovaries, the hormone discussion happens before surgery. You should understand what surgical menopause is, what the symptoms are, and what the plan is for managing it from day to day postoperatively. Fifth, you should be offered a referral to a sexual medicine specialist, either pre or postoperatively, or a menopause specialist if you are having existing concerns, and a low threshold postoperatively if things don't feel right. You have every right to this conversation. So if your surgeon is dismissive or doesn't have time or tells you most women do fine, ask for more. Ask specifically. Write your questions down and bring them. Okay, here's a concrete list to take to your pre-surgical appointment. Is my cervix being removed? Why or why not? Are my ovaries being removed? What is the reason? What surgical route are you recommending? Abdominal, vaginal, laparoscopic? I want to talk about how this surgery might affect my sexual function specifically. What are the alternatives to a hysterectomy for my condition? And hopefully you've had those discussions before you're at a pre-op appointment. Should I see a sexual medicine specialist? If the surgery has already been planned, I know some of you are listening and this is not about before a hysterectomy, but after. Maybe things feel different. Maybe orgasms aren't what they were. Maybe you've lost something you can't quite name, or your doctor has told you you're fine, everything looks normal on the exam, and you just need to give it time. What you're experiencing is real. It has a physiologic basis. Nerves were affected, structures were removed, hormones have been shifted. These are not imagined changes, and everything looks normal on exam does not mean everything is unchanged in your experience of your body. Because the standard pelvic exam doesn't measure sensation and arousal and neurologic pathways that govern orgasm. You are not being dramatic. You are not failing to adjust. You are describing something real. And I mean this with full clinical confidence. There is help. If you haven't had a comprehensive hormonal evaluation, start there. Estrogen, testosterone, DHEA. Sometimes the fix is as simple as hormone therapy that was never initiated or was discontinued too early. Local vaginal estrogen alone can be profound for tissue health, lubrication, sensation. Pelvic floor physical therapy is underused and often transformative. I love pelvic floor physical therapy. They work on the internal scar tissue and pelvic muscle tone and coordination and the nerve pathways that govern sensation and arousal. If you haven't been to a pelvic floor PT, go ask for that referral. A sexual medicine specialist, a physician specifically trained in sexual dysfunction, can do a complete evaluation The International Society for the Study of Women's Sexual Health has a provider directory. And so you can go to ishwish.org. That's ISSWSH.org. I encourage you to look there for somebody in your zip code. And for those whose preferred pathway to orgasm with deep or internal experience has generally changed, clitoral stimulation, which is not affected by hysterectomy, may offer a route to orgasm that feels satisfying, even if it's different from what you knew before. The clitoris is, according to the neuroscience, the most densely innervated part of the human body. It's worth exploring intentionally, including with a vibrator, with a partner, or with the guidance of a sex therapist. So I started this episode with an admission, and I want to end it with something I like to call a commitment. I perform hysterectomies. I will likely continue to perform them. They are sometimes the right answer, sometimes the necessary answer, but I can do better in my surgical counseling at making sure my patients know what they might be signing up for. The research is clear that the effects of hysterectomy on sexual function are real, individual, and dependent on factors that we can actually discuss before surgery if we choose to make the time and have the courage to bring it up. So thank you for being here. Ask the questions, know your body, advocate for yourself. And if your physician isn't making space for the conversation, find one who will. Until next week, be well. Thanks for listening. This episode is sponsored by Sky Women's Health. If you love this episode, follow the show so you never miss one. Share it with the women in your life and help more people discover it. Let's make it binge-worthy.